Students need guidance in the transfer of knowledge to specific client contexts. Novice practitioners often see clinical decision-making through a narrow lens. The preceptor will guide and coach a student's learning experiences to help that individual connect the dots between theory and practice. Given the increasingly interprofessional nature of clinical practice, this means being able to communicate within one's discipline as well as to various members of the team. While various professions may use different labels to identify the steps in clinical reasoning, they involve the following: 1. Recognition. 2. Appraisal. 3. Formulation of actions. 4. Implementation of actions. And 5. Evaluation. In their 2009 research about helping novice nurses make effective clinical decisions, Gillespie and Patterson created a model that can be applied to all health professions students. It incorporates context, foundational knowledge, decision-making processes, and thinking processes. Let's look at a diagram of the model. The outer dotted circle represents the context of practice. There are 3 levels of context to consider. The micro-context is that which exists between the student and the client. The next level is the meso-level, which is the practice setting. The last level is the macro-level. This level includes the broad context of government, society, and the profession. Gillespie and Patterson state that these contexts are important to understand as they highlight the matrix in which health professionals make their decisions. This reminds us of the importance of effective communication and collaboration in clinical decision-making. These contexts point out the relational nature of practice, and inherent in these are ethical considerations. As well, this component of the model recognizes that each client encounter is unique in its context. The house in the center of the model represents the foundational knowledge that is central to clinical decision-making. This helps us see the complexity of knowing that must be brought to clinical decision-making. This aspect of the model points out that as health professionals, we not only need to have knowledge, we must also be aware of how we come to learn about things. Knowing the profession is the knowledge of standards of practice, competencies, skills, and the role of the health professional in the care of the client. This type of knowing acknowledges scope of practice. Knowing the self is the knowledge of individual strengths, limitations, skills, experience, assumptions, preconceptions, learning, and other needs. It is critical to consider one's values, beliefs, and biases, and how these influence the client care transaction. Knowing the case is knowledge of pathophysiology, patterns that exist in typical cases, predicted trajectory, and client responses. It is knowledge attached to a specific diagnosis or profile. This type of knowing is often the one most valued and tested. Knowing the client or patient is knowledge that is specific to the individual or family or community. It includes objective baseline data and the examination of patterns of response to various treatments or approaches used with the client. Knowing the person is knowledge that is derived from the subjective data. It is an appreciation of the lived experience of the client based on their past experiences, patterns, preferences, and supports. It includes knowledge of strengths as well as challenges. Last but not least is the thinking component of the model. The phases of clinical decision-making include cues, judgments, decisions, and evaluations of outcomes. Let's look briefly at each phase. Cues are derived from the observation of a client and come through assessment, conversations with the client or others, a review of documentation such as lab results or school files, and as one becomes expert in practice, they come from intuition. Judgment can be linked to a conclusion at a point in time based on the cues that have been considered. It is important to realize that judgments are dynamic, so a health professional must remain open to revising the judgment as new information becomes available. You may recognize this as generating a hypothesis, testing it, and revising it. If a practitioner is unable to reach a conclusion, they must consult others who can help them arrive at a judgment. Questions a clinician might ask include, what could be happening? What data or evidence supports this? Do I need more information? From whom or where? What priority does this have? Decisions require consideration of both what should be done and how that should occur. Important considerations at this phase include: should I wait and watch? Should I try something? Should I inform someone? Should I involve others or consult someone else? How will I know if I made the best decision? The final phase of the clinical decision-making process is evaluation of outcomes. Questions to consider in this phase include: did the decisions achieve what I wanted to happen? Should I make another decision? Should I collect more information? Whom should I involve or consult? It is important to assess the client's response to the decisions and always include them as a partner in the decision-making. Let us now examine 2 case studies to apply your understanding of this model of clinical reasoning.